Another highly prevalent psychiatric condition due to HIV is HIV encephalopathy. This is defined as a progressive subcortical dementia with non-specific CSF abnormalities and cerebral atrophy with ventricular dilation. This is prevalent in 20 to 25% of HIV-positive patients. It is important to distinguish this condition to other psychiatric illnesses like bipolar mood disorder and schizophrenia. Symptoms to look out for is difficulty concentrating, disorientation, motor signs, subtle mood changes, and withdrawal. Good indicators are a person with no past personal history and no past family history and other atypical features. Complications of HIV encephalopathy may lead to a progression to HIV-related dementia. The first psychiatric condition we're going to be discussing is depression. The development of depression is a common response to the diagnosis of HIV infection. Patients are at a higher risk of suicide during this vulnerable period. The severity of HIV disease, loss of health, decreasing level of functioning, and anticipatory loss of life can cause bereavement. Patients typically experience feelings of sadness, insomnia, poor appetite, and weight loss, many of which are common to major depressive episodes, but are of a shorter duration. This can manifest as a problem for the patient when they are diagnosed, as well as affecting the family and friends of the patient after death has occurred. Somatically, it is difficult to diagnose depression at a later stage, as HIV and depression share a similar phenotype or behavior between patients who have HIV and depression. So, you need to inquire about a patient's tearfulness, self-esteem, and deteriorating relationships to be able to pinpoint. The second psychiatric illness we're going to be discussing is anxiety disorders. Anxiety disorders may manifest throughout the course of the infection, although patients are more likely to become a problem as the illness progresses. Physical pain and suffering, concurrent alcohol abuse, poor family support, and the presence of AIDS in a spouse may increase the incidence of anxiety disorders. Post-traumatic stress disorders and panic attacks may also occur as a response to the diagnosis of HIV infection. AIDS phobia can lead to anxiety disorders, panic attacks, hypochondriac beliefs, and obsessive-compulsive disorders. This is often associated with misinformation and inadequate health education. Another highly prevalent psychiatric condition due to HIV is HIV encephalopathy. This is defined as a progressive subcortical dementia with non-specific CSF abnormalities and cerebral atrophy with ventricular dilation. This is prevalent in 20 to 25% of HIV-positive patients. It is important to distinguish this condition to other psychiatric illnesses like bipolar mood disorder and schizophrenia. Symptoms to look out for is difficulty concentrating, disorientation, motor signs, subtle mood changes, and withdrawal. Good indicators are a person with no past personal history and no past family history and other atypical features. Complications of HIV encephalopathy may lead to a progression to HIV-related dementia. Investigations we can use to exclude HIV encephalopathy is to do a CT scan to exclude all physical abnormalities which can be a cause, and also we can do a lumbar puncture to exclude all the infective causes which can cause similar symptoms. It is also important to do a physical as well as a psychiatric examination to rule out all the other differentials on your list. The most important stage in the assessment of the patient is to stage the illness clinically and to decide whether or not the new presenting psychiatric symptoms are of a consequence of HIV infection. In terms of management, you need to ensure adequate support for both the family and the healthcare services. You need to investigate to exclude other medical causes such as the metabolic abnormalities. You need to assess their current medication for potential side effects. Patients with serious conditions such as HIV-associated dementia should be referred to a secondary or tertiary institution where psychiatric consultation is possible.
Another important cause of medical psychiatry is syphilis. Before we start this, we'll do a quick recap on what the condition is. So syphilis is a sexually transmitted disease caused by the bacterium Treponema pallidum. It is important to note, though, that it is not actually just sexually transmitted, but it's sent via body fluids. Therefore, it can be sent via anal, oral, vaginal sex, any compromised skin, any contact with any syphilitic ulcerations, mucous membranes, mother-to-child transmission via congenital syphilis, or any sharing of needles. In terms of pathophysiology, the spirochetes, which are the treponema pallidum, enter via mucous membranes or dermal abrasions. These enter the lymphatic systems. They then enter the systemic circulation, where they can cause inflammation of the small blood vessels, called endoenteritis, and they can cause a TAFO hypersensitivity reaction. The most important stage for psychiatry is tertiary syphilis, and in particular we're going to be talking about neurosyphilis. This can present in two ways, early or late. In early syphilis, it can be asymptomatic, or it can present as syphilitic meningitis. In meningitis, you have the normal triad, headaches, photophobia, or nixtsyphilis. In late syphilis, you can present as meningovascular syphilis, tapes tosalis, journal paresis, or Eichel Robertson people, which we'll talk about in the next slide. Okay, so the most important part to now talk about is what's actually causing the psychiatric symptoms in syphilis, and in particular we're talking about neurosyphilis or tertiary syphilis. So as we said, the two main forms that it presents, which is meningovascular neurosyphilis, which occurs in about 5 to 10 years, and simply said, this is inflammation of the small blood vessels supplying the meninges, the brain, and the spinal cord. This commonly presents with stroke syndrome involving the middle cerebral artery. The second most important form is the one that involves the parenchyma. Now in this case, the T pallidum actually invades the actual parenchyma of the brain or the spinal cord. The first form I'll talk about is tapes tosalis. This is when there's damage to the sensory nerves in the dorsal roots of the spinal cord. This results in loss of vibration sense, proprioception, loss of sensation, pain and temperature, areflexia, and probably a white ataxic gait. General paresis involves a widespread parenchymal invasion causing cell death and atrophy, resulting in cortical function decline. Due to this cognitive decline, patients can eventually have cognitive, personality, and psychotic symptoms. These include personality changes, loss of ambition at work, memory lapses, irritability, apathy, withdrawal, emotional lability, and so forth. Eventually, these patients end up having dementia. All patients showing any signs of psychiatric conditions need to have a workup done. The following investigations are done at hospitals too. This includes an RPR screen, VDRL, FTA or TPHA. CSF can be done too, and it's characteristic of high number of leukocytes, predominant lymphocytes, and high protein levels in the cerebrospinal fluid. Dark-field microscopy can also be done if available. So early infection can be treated by bicillin, also known as intramuscular benzaethine benzapenicillin. Late infection can be treated with intravenous penicillin. And obviously if there are any allergies, you'll switch the medication accordingly.